Welcome, and thank you all for joining us today for the AHRMM webinar, the Healthcare Supply Chain Response to COVID-19, Provider and Supplier Collaboration. This case study will focus on Providence Health's rapid decision and conversion of anesthesia circuits to meet COVID-19 challenges through their partnership between supply chain, clinicians, and Medline, their supplier. I am Shana Beresin, Senior Education Specialist with AHRMM, and I will be moderating today's session. All lines have been placed in a listen-only mode, but please ask your questions by typing them in the Q&A box. You can find that by hovering your mouse at the bottom of the WebEx browser and clicking the ellipses icon, the one with the 3 dots, and then click Q&A. The Q&A discussion will be held at the end of the session. So today we are thrilled to welcome our speakers, the team at Providence Health, Kate Mulligan, Karen Stewart, Mark Urson, Mark Ferrone, Dr. Frank Schramm, and Dr. Jimmy Chung, as well as Travis Sattler from Medline Industries. Thank you all for joining us today. I'm now going to turn the presentation over to Dr. Jimmy Chung. Dr. Chung?
Great, thank you so much, and thank you for the opportunity to share our experience. I think what we'd like to do is just share with you our experience as the first hospital system in the United States that experienced the COVID patient in the United States, and what our early urgency was to help our patients and help our organization to get ready for the surge, and then spend most of our time hopefully being able to talk about how having a strategic alignment with our supplier partners really helped us get ready and accelerate our work. So just to give you a quick review, our organization has 51 hospitals across 7 states, and you can see how large we are. And obviously, we're one of the largest groups in the United States, a nonprofit faith-based organization, and we had the distinction of having admitted the first confirmed COVID case in the United States on January 21st, and this occurred in one of our hospitals in Everett, Washington, at the Providence Regional Medical Center in Everett. So on January 21st, we reported the first case in the United States. This was a young man who had recently visited China and came back to the United States. And actually, he came back to the United States on January 15th and was asymptomatic and didn't have a fever at the time. So he passed through all the screenings, but then was feeling ill, and on January 19th went to our urgent care center. We were actually very attuned to what was going on in the world and was prepared for potential patients with such symptoms. And so we tested him right away and asked him to self-isolate when he got home. And then once we got the test back at that time from the CDC that it was positive, we immediately admitted him to the hospital in isolation. He actually did have a rocky course, but did end up getting discharged from the hospital. Just to give a perspective of what was going on at the time, when we admitted this patient in the worldwide, we had only had 300 cases just in 6 countries, and there were only 6 deaths reported, all in China. And then on February 29th, we experienced the first death in the United States reported at the time in the state of Washington. Of course, now we know that most likely the first death was on February 6th in California, but at the time we didn't know that. And we had reported the 10th US death on March 4th. So we knew this was happening very quickly. And when we had a predictive model, when we developed a predictive model to see what this would look like for our organization, just in that Everett hospital alone, when we predicted the peak to occur sometime in late April, and this was on March 18th of 2020, when we expected the peak to hit us late April, we expected that we would need 181 ICU beds, which is more than 3 times what we have currently at that hospital. So obviously we were extremely concerned, and without having any additional knowledge, and this was before social distancing had been required in the state of Washington, so we didn't know what the effect of flattening the curve would look like. So we were starting to scramble and looked at our projections at that time for all of our regions, not just that one hospital in Everett, and it turned out that our need for ventilators was going to be much higher than we had at the time. So we immediately went into action to try to figure out how we're going to meet that demand, and decided that we needed to start working on converting anesthesia machines to ventilators. So this work was not unique. Obviously, lots of other hospitals in the country were looking at it. We expected that there would be a ventilator shortage because of this, and the American Society of Anesthesiologists, as well as the 3 major manufacturers, were already putting out documents on how this could be done, and FDA provided a temporary approval. We calculated that we had about 1,700 ventilators that could be used in for intensive care unit patients. Obviously, there's more than just COVID patients. There's other patients who need ventilators too, so we kind of had to allow for that. And we counted about 800 anesthesia machines across our system with multiple models. At this point, we were already starting to stop doing elective surgeries, but we still needed to allot some of them for emergency surgeries. So, so we had to try to figure out how many of these machines could we potentially convert to a ventilator, and start researching how this would be done. Now, the actual process of converting an anesthesia machine into a ventilator is extremely complicated. It's not as simple as just unplugging it from one room and rolling it into another room and plugging it in. It actually takes a lot of both clinical as well as operational and IT type issues that we had to look at. So we started a mini project to educate the rest of the system, all our 51 hospitals, on how to do this. And we began with an SBAR that to initiate the system-wide project. We developed a playbook with step-by-step instructions, which will provide some of those pages for you. Identify key stakeholders and leaders and create an education plan. So obviously, it's a long list of stakeholders. You'd think it's just a simple task of taking a machine from one room and into another, but it actually turns out, as we will see, exactly how complicated this is. And part of this work really depended on working with our supply chain folks, which is here abbreviated as REH. The supply chain group in our Providence organization is called Resource Engineering and Hospitality, so it's REH, as well as we discussed IT and working with our suppliers. So converting the machines into a ventilator, again, is extremely complicated. There are different machines for different purposes, although you can effectively use an anesthesia machine as a ventilator, but it requires a different set of skills, and it's run by different professionals. As most know, that ventilators are run by respiratory therapists, but anesthesia machines are very much sort of manual, hands-on machines that require a lot of monitoring and maintenance that only certain professionals are trained to do. So we had to work on that. We also had to work with our Epic team to make sure that the EHR interface would work in an ICU setting. And the fact that anesthesia machines are generally used for a few hours at a time, they're not really designed to be on constantly. There's a lot more monitoring and maintenance required. So we had to meet a lot of different challenges, such as logistical challenges, thinking about privileging as well. If we put anesthesiologists in the ICU, what can they do and what can't they do? But primarily what we wanted to focus on was whatever we ended up doing, we had to make sure that we focused on protecting the patient, protecting the caregivers, and protecting the machine. And as we ran through this, this education process, we figured out that there were lots of different products that we actually had to reconfigure to meet the clinical standards that were coming out at the time. So we worked very closely with our supply chain team as well as our supplier to work this through. So that's the situation we were in. And I'm going to just briefly show you the next 3 pages that are part of our playbook. These 3 pages were developed to inform the leaders in our organization what they would need to do to actually start preparing for the possibility that an anesthesia machine would have to be turned into a ventilator. Now, thanks to very effective social distancing here in the state of Washington, we actually were able to flatten the curve pretty effectively, and we actually didn't have to convert any of our anesthesia machines into ventilators. But that said, I talked to a number of different colleagues across the country, like in New York City, where they did do that very frequently, and they confirmed that it was a lot of work. A lot of the things that we did here was validated. So on that note, I'm going to pass this over to Dr. Frank Schramm, who is our chair of our anesthesia focus group at the system level, who led much of the work on clinical validation of the work that we were doing. So Dr. Schramm?
Thank you, Dr. Chung. I appreciate it. So Dr. Chung has already covered a lot of the logistical issues associated with the conversion of our anesthesia machines to ICU ventilators. And I'm going to just basically go over a few of the housekeeping issues associated with it. In particular was finding out how many anesthesia machines we had, where they were, and what their specifications were, and to also plan for deployment and staffing in advance of the anticipated need, which was looming rather quickly for us. So it was an issue of repurposing not only our machines, but our personnel, and also a need to consult with our intensivists as regards their needs and their input into how we would employ these machines. They are rather labor intensive in comparison to a CCU ventilator, which is really kind of a set it and forget it machine. Ours are machines that are designed for minute-to-minute manipulation of parameters in the operating room. And as a result, they do require frequent observation and potentially even intervention to maintain maximum efficiency and effectiveness for the patient, along with safety, which requires routine rounding on the part of an anesthesia professional. It was identified early on that respiratory therapists and critical care physicians would not have time or the ability to learn the nuances of our machines in terms of the management of a patient. In particular, the most significant difference between an anesthesia machine and a CCU ventilator is the fact that the anesthesia machine recirculates gas. It's a rebreathing system. And as a result, we use carbon dioxide absorbers, and all of this is designed to maximize the efficiency of the machine and to minimize the waste of rather expensive volatile anesthetic agents. And so there are a lot of parts of the machine that are not present on a CCU ventilator. So it was an issue of creating schedules for people to round on these machines and to evaluate them. There are issues associated with humidification on the patient's part, which are deleterious to the function of the machine. We had to also assure that we had adequate pipeline or wall air and oxygen to run our machines. In addition, there's the issue of exhaust gases and how they would be handled. There was also raised the issue of O2 supply for the hospital, because for our machines to function, we had to use very high fresh gas flows, which are unusual in the operating room. In particular, there's one brand of machine that we felt might have to actually have a biomedical conversion of the drive gas for their ventilators from oxygen to air to help in conserving the hospital's oxygen supply. In particular, there are some specifics that based on each manufacturer. Of the three major manufacturers, we got newsletters from all the manufacturers, which helped to identify particulars associated with the use of their machines in the ICU setting. At the same time, the Anesthesia Patient Safety Foundation and the American Society of Anesthesiologists were jointly publishing information in the forms of frequently asked questions and position statements about the safe use of these machines in this setting. In particular, one of the things we recognized was the fact that we would have to have filters capable of high filtration of viral load, in particular filtration of 99.99% of all materials of 0.3 microns and larger. And so most circuits do come with one filter, and the question arose, well, what is the viral efficiency of that filter? So it required a bit of legwork with our manufacturers to actually get specifications for the filters to make sure that what we had was adequate, and if it wasn't, what we were going to use to replace it. At the same time, a recommendation was made by the American Society of Anesthesiologists that a second filter be placed to protect the anesthesia machine, even though the first filter was in place, because at 99.99%, there's still some potential for contamination in the machine. And at least one of the manufacturer's recommendation was that if the machine became contaminated, that the only method that could be used to make it safe for use again was to quarantine the machine for 3 to 4 weeks, which of course would mean that you were significantly limiting your supply. And so we and every other department of anesthesia in the country embarked on a search for additional HEPA filters that met the requirements. In addition, there were specifics associated with how we would manage patients on those machines. In particular, we had to be able to monitor entitled carbon dioxide because of the semi-closed nature of the circuit and the potential for accumulation of carbon dioxide. As far as some of the machines were concerned, that became a problem because the sampling of that gas could potentially be reintroduced into that semi-closed circuit and contaminate the machine. So it was very important for us to procure these filters and have them in an appropriate series. There are other particulars associated with machines that you see here, and I'll just go ahead and move through that because I know it's not a matter of great interest. And I just spoke to the fact that we had to be able to monitor expired gas during the care of these patients. And the issue of maintenance of ventilatory humidification was also an issue. Also talked about the fact that there were questions about what kind of fresh gas flows one might use, which all impacted the filter issue, because at lower fresh gas flows, more fluids from the patient accumulate and render the filters less efficient, which requires more frequent changes. And again, we were running into this issue of, will we have enough filters? And in spite of sourcing the entire continent, the globe in fact, along with everyone else, we found that there was a significant decrement or a significant problem in terms of acquiring adequate filters for what we perceive to be the coming need. In particular, that resulted in us reaching out to our vendor, who we had already been working with on circuit configurations for our entire system, for the entire 51 hospital system, through our anesthesia focus group, which is a system organization that basically vets decisions for all anesthesia groups within the system. And in particular, the issue of the second filter became problematic because most folks did not have access to them. And the fact that we would end up discarding a number of these circuits and filters during what could be a prolonged episode of care. The average length of stay on a ventilator for a COVID patient is between 10 and 14 days. So you can see that this could potentially be a significant problem. In particular, the Anesthesia Patient Safety Foundation published a diagram that you see on this slide, which shows a high efficiency moisture trapping filter at the end of what we refer to as the Y, which you can see there, and the gas sampling that I spoke about before, which is on the machine side of the filter to avoid contamination of our machine. The additional filter, the high viral efficiency extraction filter, is located on what's referred to as the expiratory limb, which would then protect further the anesthesia machine from contamination with the virus particles. And you can see in the picture to the left, we have a configuration, an initial configuration of a circuit with our vendor that had a HEPA filter, the yellow filter that you see at the Y, but we needed an additional filter. And so in working with our vendor, we were able to source and create a new circuit design which complied with this recommended configuration, in which there's a high efficiency viral bacterial filter placed in the expiratory limb of the circuit, and they would be provided to us in that configuration without us having to search, rather, I'm afraid, fruitlessly, for additional filters to protect our anesthesia machines. And with that, I will turn it over to our supply chain folks.
Hello, everyone. This is Mark Urson. I'm sourcing and contracting manager, and have been with Providence for over 20 years. And so I just wanted to give kind of a background on our supply chain efforts, both with the anesthesia group as well as with our supplier. So let me start with saying a couple of years ago, we started the resource engineering and hospitality group that Dr. Chung mentioned, and that's also known as the supply chain team to the rest of the world. And we partnered with our anesthesia focus group and all of the departments throughout the 51 hospitals in the Providence St. Joseph's Health System on an initiative to really inventory all of our anesthesia machines to develop a replacement plan. With about 800 machines identified, we had a significant number that were at or near end of life. These numbers really forced us to develop with our finance department a replacement strategy that would take really years to complete as funding was identified. The impact of the COVID-19 will certainly impact our ability to follow through with that plan as originally mapped out. Nevertheless, our capital strategy initiative provided a platform for us to engage with our anesthesia department. In reviewing the usage data, it was evident that bringing standardization to our anesthesia masks and circuits was a big opportunity for standardization. And clearly, we needed to provide circuits and filters that met the clinical needs. As Dr. Schramm mentioned, we started off with one configuration, and as a result of identifying some realignment of our clinical needs, we came up with another configuration, and that was really to make sure that we provided safety for our patients, our caregivers, and that the products met the criteria for both use in the OR as well as being deployed as ventilators in the ICU. Furthermore, we needed to protect, as mentioned before, our anesthesia machines from contamination, which would take them out of service for weeks, and that was just a luxury that we did not have. To accomplish that, we needed to partner with our supplier to assemble the right product during a time when everyone was drawing on the same supply sources for the critical components. Once our product was assembled, we had to bring it into our system without using our traditional conversion processes. And I think Kate's going to cover some of the logistics challenges in a bit. Next slide, please. This effort would have been nearly impossible without the framework that we had established for a strategic partnership with these suppliers. Many of us surely have had business reviews with large suppliers where they tell us how we are not or are complying with the particular agreement. Our particular strategic partnerships are more of an exchange of information whereby the supplier provides their assessment of how the various agreements are progressing, and that the Providence team provides their assessment of the vendor's performance based on predetermined metrics. For example, timely delivery, back orders, percentage of EDI orders processed without error, pricing discrepancies, service and support, to name a few. The overall objective is to get a market-leading pricing by improving efficiency and taking unnecessary costs out of the healthcare system for both the system and the supplier. Strategic partnerships are comprehensive relationships that, when done well, focus on cost-effective clinical outcomes and deliver value rather than individual line item savings. This allows us to leverage established internal teams, namely the supply chain, clinical resource integration, with our suppliers team. Because we have a strong term or a long-term commitment to one another, we expect strong product availability, especially during critical times of crisis, as been presented with COVID-19. So to add a little of context of what we faced with our response to the COVID-19 situation, next slide, please. Our work with the anesthesia circuits was well underway before COVID-19. We were using about 20,000 units or circuits per month. And we identified there were roughly 30 different configurations that originated over years of facility-based practices and little or no emphasis on standardization system-wide. With a focus on reducing variation in our circuits, we relied on our supplier to help us pivot in real time from our usual implementation process, which was already underway, to rapidly developing a circuit that met the ASA criteria and could be used throughout our system with minimal change in practice. Without trust and collaboration, we could not have moved from planning to production to deployment in such rapid order. And now I'd like to turn it over to Karen Stewart from our Clinical Resource Integration team.
Thank you, Mark. Again, my name is Karen Stewart, and I am part of what is called Clinical Resource Integration, which means I'm a clinician who works for supply chain. There's a team of us for the various specialties throughout our health system, and our goal really is to make sure that we have the proper communication going on amongst all of our clinicians, supply chain, and our vendor partners. So next slide, please. As we've heard on the presentation to this point, essentially we had been doing a lot of work as a health system to build relationships so that we had a good concrete process already in place in working with our teams well before COVID arrived in our facilities. The challenge, though, as you can imagine, that no matter how much you plan for the surprises, COVID was its own world. As you heard also, Providence St. Joseph Health had been working very closely for years in all of our clinical specialties in establishing product selection processes that involved, again, our clinicians and supply chain and our vendor partners. Just recently, the strategic partnership aspect had come into place that Mark was sharing with you, and that has helped to really formalize the process and provide that consistency that we had been looking for. As you can see, the anesthesia circuits for COVID patient care were critical. We knew in supply chain, as well as at the clinical level, that now that COVID had arrived, our concern was absolutely for the supplies, for our patients, and for our caregivers for their protection. What was so helpful is that the clinical leaders that were involved and our team members already knew that our health system put the care of the patient first. Our supply chain already had the knowledge of the various pieces and parts that were available, had already started the process of searching out in the community and the world, as Dr. Schramm had mentioned. And with that relationship with our vendor partner already established, they too knew what we used as a health system and what was going to be needed for this crisis. Again, we didn't have to work at putting together a process. We didn't have to work at getting the right people in place to work with the scenario. because of our efforts previously, those things were in place so that we could immediately mobilize our efforts. Again, working with Dr. Schramm and the anesthesiologists throughout the system, we wanted to make sure that those clinical requirements were being met, especially by the regulatory or professional groups. We already had that pipeline to that group because of our previous anesthesia work. So when we had questions or confusion in regards to clinical aspects, we had resources very readily available. Also, again, our supply chain, REH, we knew what we had available as close as possible as any supply chain can at the time. We also had processes in place for looking out more broadly in the world for those available pieces and parts. But what we also had, again, with our vendor was the fact that we had been working with that vendor on numerous clinical issues through our health system, looking at conversion processes and various specialties. And so the vendor knew how we as a health system operated, knew what our priorities were. Again, as I mentioned, we didn't have to put the wheel together. It was already formed and effective. So those three teams, as we mentioned, the clinicians, supply chain, and vendors, the communication that we had already established, the panel, the pathways, again, the trust from having worked numerous projects together prior to this time allowed for that teamwork that smoothed the process and expedited our ability to get what was needed for our clinicians as quickly as possible. Kate Mulligan is now going to share with you how we actually got those products into our clinicians' hands.
So as Karen mentioned, I'm Kate Mulligan. I am our implementation manager for our clinical resource integration team. I work very closely with Karen Stewart to implement conversion projects to all our facilities in our system. As Karen mentioned, we now had a product that was clinically verified and approved and met those ASA and compliance guidelines. But now how do we actually get that product into our facilities on a 50-plus health system basis? So our team had to come up with a plan to quickly and efficiently get these into the hands of our caregivers. And Medline worked very closely with us. As I think everyone has noticed, there's been a pattern throughout this process, and it is that our communication was heavily established prior to the COVID situation, which allowed us to easily pivot. Now, to get these products into the hands of our caregivers, there were two major challenges that arose. One was that we had no visibility into where these products would be going because they weren't actually located in our inventories. And the second challenge was we had two different inventory management platforms for our health system, but we were looking at a system-wide approach to the process. So our temporary rapid solution was to create what we call hub centers. This is where we would ship product directly to a ministry or a warehouse that was centrally located in our regions. They would then receive it into their inventory, and then it would be shipped out to the surrounding ministries around that hub center. And we needed strong communication with our local supply chain team support, because we had to initiate transfers from those hub centers into the inventories at the ministries that surrounded it. So this hub strategy, it allowed for one, visibility by receiving those circuits into our inventory at the hub locations. Two, it allowed visibility to the usage volume in each of our facilities by that transfer. And three, it allowed for a system-wide approach for two different platforms in our 50-plus ministries. So the next challenge we faced was the communication aspect. How do we communicate this completely different process to materials management? And at the same time, how do we communicate to our clinicians all the background information that you heard Dr. Schramm and Dr. Chung and Karen Stewart mention of all the clinical efficacy information, and how do we get all of that communication in a clear, concise manner out to our local supply chain as well as our clinicians to support their work. So what we did is we created SBARs, which stands for Situation, Background, Assessment, and Recommendations. These are one-page documents that for our health system are extremely familiar communication tool. We wanted to create something that everyone is used to seeing, whether you're a supply chain worker or a clinical caregiver. So our team collaborated on 2 one-page documents. The first one was tailored to our inventory control coordinators and allowed for us to communicate the hub centers, what it would look like, who was the hub center in the different regions, and how to initiate those transfers. Again, as having 2 different platforms, we had to kind of communicate that in 2 different ways, but looking for an overall system approach. And then one to our clinicians, which went into more details about the filtration and things like that. What we also did was we put a link at the bottom of our inventory control SBAR that referenced our clinical SBAR so that if a clinician came and had questions about ordering or anything like that, that inventory control or supply chain person had reference to the communication that went to the clinical caregivers on that side as well. So as Karen mentioned, our already established relationships allowed for this rapid communication and allowed us to pivot very quickly. The challenges we faced throughout this process really brought better visibility into areas of opportunity for process improvement post-COVID. Our team was able to build that trust in our system approach, both with our clinicians and our local supply chain. Overall, there have been a lot of positive opportunities generated as we move forward in partnerships as we move forward as a health system. So now our partners with Medline are also on the call, so I will go ahead and turn it over to them now for their perspective.
Afternoon, Travis Halter here from Medline. So when Medline and Providence first teamed up on this initiative, it was clear from the beginning that data was going to be a major driver in this conversion. Medline and Providence collaborated to share data points freely between each organization. First, we identified Providence's challenges, supply issues resulting in back orders and disruption to the supply chain, multiple configurations of circuits that led to potential variability of care across the facilities, 10 different SKUs, all serving the same purpose and specification coming from multiple manufacturers. Physician preference items. Providence handled this very well with their anesthesia subcommittee, making the necessary decisions and research and then pushing them out to the individual ministries. It was critical for this to come from the anesthesia subcommittee, not from a Medline sales force. As I'm sure you all know, these challenges lead to increased costs, decreased efficiency throughout the supply chain and the OR, as well as variability of care, which we are all looking to reduce through this partnership. Next, we looked at the data to try to understand why there was so much variability within the health system. Was it just preference? We had 5 different circuit manufacturers with over 30 configurations. When we looked at the accessories, they were just all over the board, as I previously stated. Next slide, please. The data mining led us to in-person observational utilization reviews within each facility, led by myself and our other specialists. Meaning we were in the field working with the end users, seeing how they were using the products, and then making recommendations based upon that. Our goal was to simplify the anesthesia supply chain, storeroom, and not just focus on circuits, but also the other anesthesia accessories in this space, looking at the whole produce section instead of just one apple to one apple. And the SKU duplication due to supply issues that resulted in other SKUs? We didn't know, but we knew we could fix it. We presented the consolidation of SKUs to the subcommittee as well as the recommendations of circuit configurations. The circuit configurations were based on the facility's top needs identified in our in-person reviews as well as the subcommittee's clinical requirements. This would then ensure consistency of care across all of the Providence ministries. The subcommittee then communicated this to all the respective Providence ministries. Next slide, please. Including this led to the solution that simplified their ordering, reducing their touch points, and decreasing labor costs. Most importantly, this process allowed Providence to move quickly with Medline once the COVID-19 pandemic started. We already had a trusted partnership and had the right personnel in place with a pipeline established for the product. We were aware of Providence's needs. We were able to establish timelines that met those clinical needs while being realistic given the current market climate. I didn't go into a lot of detail regarding the exact configuration of the circuits, but I'm certainly able to if there are questions about those.
Thank you, Travis. Thank you very much to everybody for your perspectives and the information. That was a lot of really important information, and we greatly appreciate it. We have the opportunity now to ask a few questions. And if you haven't already, please type your questions into the Q&A box, which you can open by hovering your mouse over the ellipses icon at the bottom of the webinar and clicking Q&A.
Shana, hi, this is Jimmy Chung. I just wanted to add maybe one final perspective, and that is that, when we look back at this and you think, wow, anesthesia circuits, it's not a real sexy topic, to be quite honest. It is a very critical component, but it's not as a sexy a topic as for supply chain folks like, ortho joints and spine implants and things like that. And in retrospect, I think it's, you can look back and say, we have a luxury now to look back and say, well, that was pretty smooth and it went easy. But at the time, as you all lived through, I'm sure, had a very similar experience when we didn't really know what the effect of all of our, social distancing and restrictions would look like and what that result would be. We had no idea what our critical care needs would be. And so, as all of you were, we were really trying to scramble at the time and staying up, late nights trying to figure out where we can get that one more ventilator and so forth. So I think, now we have the ability to kind of take a breath and look back at what the work we've done and, truly highlight the success in getting this going. Now, while we didn't have to use any anesthesia machines themselves, these circuits are still crucial in our daily use in the operating room as well as in other uses to protect our machine from the COVID virus. So this new configuration that we were able to create has saved us a lot of not just money, but a lot of headaches in terms of procuring the right product for the right use, even if we're not converting the anesthesia machines to ventilators. So it turned out to be an extremely worthwhile exercise. And secondly, we're much better now prepared for perhaps the next pandemic or another surge. There's estimates that another surge may be coming late summer or fall, or there's some who will say that the next surge would be even worse than this one, and so we have no idea what's going to happen in the future. And having learned from this experience, I think we have a lot of benefit of hindsight, but we can use that experience to know now what we can expect of our other supplier partners that we have. And I really don't want people to walk away from this as if thinking that this was a promotion for Medline or even our organization in Medline. It's really more just an example of what kind of partnership you can have with clinicians, supply chain, and supplier. And we have similar similar partnerships with other vendors, and we have arrangements with other vendors that are not so smooth. So now we know we've set a benchmark in terms of what we should be doing and what we can be expecting with all of our other suppliers as well. Hopefully that would be the message that people can take.
Thank you very much. Thank you, Jimmy. I appreciate that. We appreciate that. So there have been a few questions that have come in, and I will ask, and you can kind of decide amongst yourselves who should answer. So the first question is, were there any disruptions to the supply chain due to COVID-19, and if so, how did you handle that?
Well, this is Mark Urson. I guess I can take that. We have experienced a number of different supply chain interruptions in PPEs and HEPA filters and things like that, and we've tasked a number of teams to scour the internet, their vendor resources, really for alternatives to those particular supply problems. We've also tried to work on developing alternatives to those supplies that are in short supply in order to make sure that we're protecting our patients, our caregivers, and our environment.
This is Karen Stewart. There also is a very structured process for those COVID shortages or those COVID issues. There are established groups, COVID teams that meet daily to look at PPE, the various topics that everybody can imagine on this call, making sure, again, that infection control is involved, other clinicians, again, supply chain, those same team efforts are constantly, proactively meeting to make sure that they can stay on top of the shortages and get those alternatives as quickly as possible. So I think those established teams are really critical, even once a decision is made as to what the resources are. There's what we call a central planning team that is part of REH or our supply chain that makes sure that the logistics and the processes to obtain those items and get them, as we talked about, into the clinician's hands, that there are steps that are already established there as well.
Right. That's the most important, I think, is to make sure that those have been established, and if not, to quickly do that. And maybe what we'll do is we'll recommend one of our past webinars, which is about collaboration between the departments, collaboration with, clinical integration and how to talk with clinicians, things like that. Okay, so our next question, how is volume aggregation accomplished with two disparate systems?
Sorry, Shana, can you repeat the question again?
How is volume aggregation accomplished with two disparate systems?
This is Mark. I can field the first part of that. What we do is we have a number of tools that allow us to query both of our systems, really determine what our overall volumes are, how those are distributed throughout our system. Because we have two different ERP systems, we have to do some standardization of part numbers and things like that. However, we have a very talented group of data scientists who have managed to provide a platform for us to really pull that data together relatively quickly, and a decision support team that can do even more in-depth data extraction to help us manage the aggregation of data and usage so that we can make decisions.
This is Kate Mulligan, and in addition to what Mark Urson has shared, it's also that there's a different process maybe on the end user side. So some of our facilities use one system, some of them use the other one. So from their perspective, there's different processes that are needed to be communicated, but on the back end, we gather the same data from that team, as Mark mentioned.
Yeah, this is Jimmy Chen. I would just add that one of the interesting outcomes of the past several months for us, and probably for a lot of other organizations, is that work that we had already been focusing on was much more accelerated. Like things that we thought would take us, a year to accomplish happened within a few weeks. So, for example, our drive towards telehealth, which we were going to do anyway, really rapidly accelerated much faster than we had planned on, just because of the need. And another aspect was data conversion and consolidating of our data systems. And obviously that's still work that is in progress, but because the need arose so quickly, we really had to focus on having the right data, just even from getting an inventory of what we already have to our needs assessment and demand forecasting and things like that. So our IT folks and our clinical analytics team just really put it into overdrive for us. So they're our unsung heroes.
Thank you. Thanks, Jimmy. So another question that has come in is along the product line, and if you considered alternate suppliers for the circuits, did you have to bring in alternative suppliers for those circuits because of COVID?
Dan or Mark, what do you guys think?
Well, this is Mark again. Part of our strategy has been to really lean on Medline as our primary source. We are still working with our other vendors. However, Medline has been a wealth of information and a resource to really assist us where the gaps were with some of our other circuits so that we can then develop interim solutions to making all of those circuits ASA compliant, and that we don't have any interruption to ramping up our surgery volumes while we're building these new circuits.
Yeah, I guess maybe I could also add that just aside from circuits, we've when we during the moment of desperation, we did reach out to a number of different potential alternative solutions for ventilators, and it really surprised me how many different vendors were really out there, and I would say that also that probably not a day goes by when without an unknown vendor just kind of cold calling one of us and saying, we can get you these filters and masks, and even with these anesthesia circuits, we know you need HEPA filters, and we can get them for you, and all this kind of stuff. And it just there's a lot of noise out there, and I would just caution that while it may be fruitful to spend time investigating them, just that it would be worthwhile doing due diligence with your supply chain folks to make sure that that some of these are not kind of what they've been calling the gray market area, and make sure that that you can have you establish a sustainable model with your vendor.
Yes, and this is Karen Stewart. It was speaking of filters, as we were talking about, and Dr. Schramm was mentioning for the circuits themselves or just ventilators, it was incredible as to the number of vendors who suddenly had what they would quote as HEPA filters, for example. And then when we as clinicians really dug down into the muck, it was amazing the naming conventions or the freedom that was taken with terms or data as we found in those various vendors to make sure, again, for patient safety and clinician safety, that we truly had the pieces and parts that met the criteria, met the guidelines, because again, it was a free-for-all. I'm sure everyone else is experiencing the same thing.
I just want to thank you. We're going to have to end it there. If you have additional questions and those that were not able to be answered yet, which we do have, we will ask the presenters to answer those questions in writing, and we will send that information out to you along with the, we'll send that information out to you when we have it. Tomorrow we will send the recording and the handouts. So everybody, Kate, Karen, Mark, Dr. Schramm, Dr. Chung, Mark, Travis, thank you very, very much for a stimulating discussion. We greatly appreciate what you have shared with us. Thank you, everyone, for participating today. If you have additional questions, please email ARM at ahrmm@aha.org. Have a great day.